on the eyes. But we do have chapter 10. Welcome to week 8. We are down to, after this week, 3 more weeks. So we're going to be talking about ophthalmic agents. But the first part is really breaking down the eye. We have some poll questions, and then we're going to wrap it up. Okay. But for our quote of the week, it's often the small steps, not the giant leaps, that bring about the most lasting change. Just like in surgery, where every small action you take can have a significant impact on patient safety and care, the same applies to your learning journey. It's the small, consistent steps, whether it's going to be perfecting a skill coming up in the next module, to learning a new procedure, or just really understanding a concept. That's going to lead to the most lasting changes in your growth as a CST. So I don't want you to think, like, especially when you get into the next module and you're like, oh my gosh, I cannot figure this appendectomy. Take a deep breath and remember, you're building yourself up. It's the small steps, not often the giant leaps. Okay, so you had some questions in the intro video, but I didn't want you to answer them right now. Okay, we're not going to be like, hey, you. What I want you to do as we're going through tonight's live session, I want you to think about these questions, and I put a little notes to kind of help guide you as to what you're going to be really honing in on in tonight's live session. So one of the questions in the intro video was, how do ophthalmic agents differ from other systemic drugs in terms of their absorption and effects on the body? So you'll see I have little notes. Think about specific characteristics of the eye and how these drugs are designed to work locally. Another question that was asked, why is it critical for us to understand the methods of actions of ophthalmic agents during eye surgery? As we're going through tonight's live session, I want you to consider the role that these agents actually play in patient safety and, of course, surgical success. And there was a third question. What are the potential risks or complications associated with improper administration of ophthalmic agents, and how can these be avoided in the operating room? Reflect on the importance of proper technique and communication when working with these specialized medications. Okay, so this is broken up into 10.1 and 10.2. The first part is where we're really going to just dissect the eye. Now, full transparency, I can do eyes, but that's not my forte. Okay. So if you're going to ask me questions, just give me some time to kind of look it up and get back to you. But I can do eyes. Okay. Now, we have to understand key eye terms and abbreviations. We have to identify the main parts of the eye and show how to correctly give eye medications before we can kind of dive in to what we do in surgery. So we're going to break down the eye. Okay. And what I did is try to get images to kind of separate the different parts. Now, in the book, 10.1 shows the anatomy of the eye. But like I said, let's break it down. Now, keep in mind, the eye is a very complex sensory organ. Why? Because it receives visual stimuli like light and images. It transmits signals to the brain through the optic nerve, and that's for interpretation. Now, this process allows us to kind of see and understand the world around us. Okay. So, what are we going to be looking at? Now, the eye relies on accessory structures for proper maintenance and protection. Our eyebrows, they provide protection from sweat and debris. Our eyelids moisten and they protect the eyes. Our eyelashes, believe it or not, they trap particles and protect the eye. We have a lacrimal system that helps with tears, and it also removes just eye surfaces and keeps the eye moist and clean. Now, These structures are important for just maintaining our eye health, and they function during and outside of surgery. Now, let's go into the eye. Okay, you see some of the terms that we're going to be looking at. Okay, we have our conjunctiva. And like you said, I wanted to break these and separate them so you can really see what we're going to be working with. This is that thin, transparent mucous membrane. It lines the inside of the eye. Okay, it covers the anterior surface of the eye or the globe. Now, what does the conjunctiva do? It's that protection of the eye. Now, you may have heard of terms like conjunctivitis, where that's the inflammation of the conjunctiva. It is a common eye condition. It presents redness, irritation, and sometimes discharge. We go into the bony orbit, okay? Now we're looking at a little bit more protection of the eye. It's like a shield. It also supports the surrounding fat and the fascia and for cushioning. We look at the globe of the eye. It is composed of three tissues, and we have our fibrous tissue. Think of the outer layer. So you have on a coat or three-piece coat. The fibrous tissue is going to be that outer coat, okay? You have your vascular, that's the middle. And then we have our nervous, closer, it's inside. These structures work together to protect and maintain the eye's function. Okay, so fibrous, outer, vascular, middle, nervous, inner. We have our sclera. This forms the outer part of the fibrous layer. This is important because it maintains the globe shape and is commonly referred to as the white of the eye. Now, limbus is the junction where the sclera meets the cornea. Okay. It's deep below the limbus. It lies the canal of Schlemm. Now, this is a venous sinus involved in kind of like draining. So it's helping with the drainage of the aqueous humor. Okay. Again, I'm breaking down each section. We get to the cornea, and you may see concepts about the window of the eye, also known as the cornea. This is the second part of the fibrous layer. It's transparent, and that's why it's often called the window, because windows are transparent. They're kind of clear, right? Of the eye. And it contains no blood vessels at all. It's avascular. So if I was to ask you, what part of the eye is avascular and is also considered the window of the eye? We're all going to know that we're talking about the cornea. Okay. It gets nourishment from the aqueous humor and oxygen directly from the air. Now, the cornea plays an important role because that's where light is being focused and it protects the eye's inner structures. You guys with me so far? Okay, so I have a different camera, so I'm going to move you guys down here so I can kind of see. Okay, perfect. Now, we have a vascular layer of the globe, which is your cord. This is the vascular. It's rich with blood vessels. So the cornea it's avascular. Your cord is very rich in blood vessels. It provides nutrients to the retina and the outer layers of the eye. We have our cilia. It's the thickest part of the cord. Okay. It secretes aqueous humor to maintain intraocular pressure, and that's really important. Okay. We have to maintain that intraocular pressure. It attaches to the lens and then it adjusts its shape for near and far vision. That's called accommodation, because you may not see near or far, you may see the word accommodation. Okay. That's where it's adjusting the shapes from near and far. I'm going to repeat accommodation. Make sure you understand that concept. Now, this vascular layer is important because it's helping managing eye conditions that affect vision and fluid balance. we get into the iris. I'm going to move you guys back. Okay. We get into the iris. This is positioned between the cornea and the lens, and it's attached to the ciliary process. Now, the thing about the iris is it controls the size of the pupil, adjusting how much light comes in and out of the eye. This process really helps to kind of regulate our vision and differentiate lighting conditions. Like if you've ever woken up and it's like really dark and then your eyes start to adjust, right? So your iris is helping that adjustment take place. Now, the pupil is the central opening of the iris. That's why you don't see it here, because I wanted to really separate the parts. Now, with the pupil, this is an opening. This is an opening, not a physical structure. Okay, I repeat, the pupil is an opening, not a physical structure. Now this actually is what's controlling the light coming into our eyeballs. It changes size through the actions of the iris, which again constricts, meaning it will narrow or dilates or widen the pupil. So constricts, narrow, dilate, widens. And that's going to be based on the lighting conditions. The adjustment is really important because it helps with proper vision when you have that varying light environment, like when you're going from a movie theater, right? You've just watched, I don't know what's out, a new movie, and then you come out and you're like, oh my goodness, it's just really bright outside. Okay, so your eyes are adjusting. Now, there are nervous layers of the eye, all right? We have our retina. See if I can put it right here. Okay, you have your retina. The retina is the inner nervous layer located at the posterior of the eye, and it's covering the choroid. You guys can kind of see, and you see where it is in respect to the actual eye. Now, what it does is it receives and processes light, like it's focusing the images. You have rods and cones. They are sensory receptors in the retina that kind of respond to light and color. Now, these receptors, what happens is they trigger signals that are sent to our brain for image recognition, and then it interprets for us. So, like, I'm looking at my camera in front of me, I'm looking at the camera, it's going to my brain and letting me know that indeed is your camera. Okay. Now, the retina is so important for just converting visual stimuli into information that the brain can actually understand. We're not done because we didn't talk about the lens. This is composed of fibrous protein arranged in onion-like layers. Okay. It is located just behind the iris and is covered by a clear fibrous capsule. It is held in place by sensory ligaments. The function is to kind of focus onto the retina. And what it does is now we have a shape and it's going to clear it up at various distances for us. The lens plays a big role in just making sure that light is properly focused for the brain to, again, process visual information. So we know what it is, but now we can actually put it together and visually it comes together. We get our ocular cavity, okay, located in the front of the lens, divided into two chambers, positioned posterior to the cornea and anterior to the iris. Now, we look at our aqueous humor because the chapter wants us to know about it. It fills both chambers of the anterior cavity. It's secreted by the ciliary process and constantly is constantly being replaced. Okay. It's like a waterfall that's constantly coming. So even when it's draining, it's going to constantly be filled up. Now it drains through the trabecular meshwork into the canal of Schlemm. Now, we talk about glaucoma. We're going to talk about that in the second half. Blockages in drainage is what can lead to glaucoma, and that's caused by increased intraocular pressure. That's one thing that we do not want to happen. Okay. In the posterior cavity, this is located between the lens and the retina, and it contains vitreous humor, which is not replaced. So Vitreous humor is not replaced, but um, aqueous humor is replaced. Make sure you understand that. Okay. Now, vitreous humor is not and serves a more structural role in the posterior cavity. It maintains the shape of the globe and it keeps the retina in place. The balance and flow of these fluids is important in conditions like glaucoma. Again, we're going to touch on that towards the second part of tonight's live session. Now, the last part of the first half looks at the administration of topical ophthalmic solutions and ointments. Now, topical ophthalmic medications, while effective, may have limitations in their ability to kind of get in and reach the deeper structures of the eye. There are methods that we have to kind of improve the effectiveness of these drugs. So you see pledgelets. These are medications soaked that can be placed in the conjunctiva cul-de-sac. That's the space between the lower lid and the eye. Now, after the eye is anesthetized, yes, that does happen with just drops, like we do local anesthetic drops to kind of numb it. Like if you've ever gotten your eye dilated, they're putting those drops in to kind of numb the eye. Same thing. This allows the medication to kind of remain in contact with the eye for a little bit longer because it's not going to irritate the patient, which is really important. And that also increases its effectiveness. Now, you also have nanoparticles that the chapter talks about. This is an area of active research amid at like really improving the delivery of medications to the eye. Nanoparticles can help really increase the absorption and targeted delivery of drugs, potentially overcoming some of like the limitations of traditional tropical treatments. So the chapter in there's a figure 10 too to make sure you guys check out, illustrates just the proper technique. And I try to put it here for you, but you can probably see it a little bit clearer in your own like little in your own book. Illustrates the proper technique for administering just those topical solutions and ointments. So make sure you have the opportunity, if you have the opportunity, to kind of check it out. Now, that's 10-1. Now let's talk about the agents that we have in surgery. Two objectives: understand the surgery meds. We're going to talk about the main types of eye drugs used in surgery. We're going to see some examples. And we have to know glaucoma meds. We got to identify main drug categories used to treat glaucoma. So let's get into it. Ophthalmic agents commonly appear on the sterile back table. They're going to include anti-glaucoma agents, anti-inflammatory agents. We have diagnostic agents. We have mitomycin. So that means that it's really important for us as STs to accurately identify and remember, trust and verify. We are not going to have anything on our back table, on our Mayo stands that is not labeled, right? Especially when the surgeon is using an operative microscope, because remember, they are not looking away from this machine. They are trusting that everything that we're handing them is indeed what they need at that particular part of the procedure. Okay. So keep that in mind. They're going to be handing their hands up to be getting those supplies, not looking up. Okay. Ideally, not looking up. So we still got to prep. We prepare the ocular region for surgery. We use ophthalmic prep solutions for irrigation during procedures because we do need to maintain a clean environment, even in ophthalmic or eye cases. So we have betadine ophthalmic 5% prep. It's a sterile brown liquid. It's stabilized by glycerin. It's going to be left in contact with the prep area for 2 minutes just to make sure that it is effective. So how do we use it? It's going to be for preps, specific for ophthalmic procedures to kind of just reduce infection. We do not want these patients to become infected. And when it's used as an irrigant, it helps keep the area clean and free of contaminants during surgery. Now, the thing with the prep, they're going to be chosen carefully, right? Because we want to protect the delicate tissues of the eye while ensuring the sterile field remains intact. So again, I'm trying to give you that visualization of what you may see. Okay. We have the eye retractor in the eye. You'll learn a lot more about that once you get into eye cases or eye procedures in module 4, but just know we're not holding the eye open. There is a retractor in place. Okay. Now, when we're irrigating solutions, it's cleansing the operative site, keeping the cornea moist, because if the eye is open and there's air going on, what could happen? It can dry out, especially during surgery with a retractor. So we're constantly trying to keep it moist. We have lubricants that protect the cornea, especially when patients are under general anesthesia in surgeries not even related to ophthalmology. You may see the anesthesia kind of put ointment on their eyes before they kind of close them during the cases. The chapter really wants you to know, and I'm letting you know, never ever use gauze sponge to wipe blood from the eye because, as you can see, it can scratch the cornea. Some of the medications that you're going to hear, you're going to see, especially on the CST exam, even on your final, concepts may come up. Balanced salt solution, BSS. If you're ever doing an ophthalmology procedure, writing it up, looking it up, BSS is going to be the most commonly used irrigant solution in ophthalmic surgeries. It's sterile, it's physiologically balanced, and it helps cleanse the operative site and really keep the cornea moist during procedures. BSS, BSS, BSS. If you see, and they're talking about an eye case, you see options of normal saline, lactated ringer, BSS, eyes, you're going to always choose the most commonly used irrigant for eyes, BSS. Hint, hint, you may see it somewhere, just saying. Now, with lubricants, we have Lactolube, commonly used just to kind of protect the cornea during general anesthesia. Again, this is not a ophthalmic one that we would use for ophthalmic cases, more for general anesthesia. Now, again, BSS cleanses the operative site. I'm going to say it again. BSS cleanses the operative site and keeps the cornea really moist during those procedures. We have to pay attention to the proper use of these solutions because we're trying to maintain healthy eye and really prevent damage during these ophthalmic cases. But those aren't the only ones we use. We have viscoelastic agents. The purpose of these is to kind of, again, protect delicate eye tissues. It keeps the anterior chamber, which is the front part of the eye, open during surgery. It can replace the vitreous humor or act as a tamponade where we apply pressure. And you can put a tamponade. When you guys get into your procedures, you're going to see there's a lot of different services that we're doing that. We're applying pressure to certain vessels, organs, etc. Okay. So examples the chapter talks about is Helon, OcuCoat, Visicoat. Again, we're trying to maintain space in the eye during cataract extraction. Shields the tissue from surgical instruments. Replaces vitreous humor if needed. Quick question. Is the vitreous humor replaced? Is that a yes or no? Do you guys remember? Is the vitreous humor or the aqueous humor? Ah, that's right, Kevin. Vitreous humor is not replaced. So remember, it's that aqueous humor. Keep in mind, thick gel-like substances, essential in modern cataract and other eye surgeries. It's pre-measured. There's that sterile syringe. So I kind of wanted to get like just different examples so you can visually see. But we're going to use a blunt cannula, and those are usually in the eye cases for precise use. Now, with myotics versus mydratics, I wanted a visualization so you can really see what one does versus the other. As you notice, one is going to have pupil constriction, vasoconstriction, because you may not see pupil constriction, and one's going to be vasodilation, because again, you may not see pupil dilation, you may see vasodilation, so make sure you know. So let's start with our pupil constrictors. They make the pupil smaller. Okay. What they do is they tighten the iris muscle, and that helps lower eye pressure. Remember, we do not want increased intraocular pressure. So this is really important for our glaucoma patients. So you see some of the the examples, Michael E, pilocarpine. Um, they're using cataract to keep that artificial lens or the IOL stable. It helps with procedures like iridorectomies. It's also, again, used for glaucoma. Then we have our dilators. Okay, again, you see the pupils, right? See the difference? With mydratics, it's going to widen the pupil for better visibility. What they do is they dilate the pupil and then they temporarily stop focusing ability. That's important because when we focus, we're kind of constricting. So now you can kind of see how our eyes work. It's useful in exams and for surgeries. So a lot of times that's why we get our eyes dilated for those of us who wear glasses. So now you kind of know. So we have atropine, scopolamine, tropicamide is another one. This allows access and visibility inside the eye by just enlarging that pupil. But there is side effects, right? For those of us that have our eyes dilated, we know that our eyes become sensitive to light. Other symptoms that you may not know: dry mouth, increased heart rate, and even eye irritation. Now, that's not saying that everyone's going to get those, but those are other potential side effects. So we look at the key differences, right? We see it in front of us. It's pretty obvious. Miotics constrict, but they lower eye pressure. Okay. Want to make sure you guys realize that. Miotics constrict, but it lowers the eye pressure. Mydratics, they dilate, stops the focus, and then it allows for a surgical diagnostic access. We have anti-infectives. They're used to prevent infections, okay, in the eye, especially in cases of the external ocular infections or to prevent postoperative infections following some type of ocular surgery. Common examples would be garamycin, neosporin, which is one we're all kind of used to hearing, but there's also Vigomax, Zymor, and Siloxane. The anti-infectives for the eye can be ointment form, especially for external infections, or as you can see with the Maxitrol here, it can be in a drop form as well. Now, for us in surgery, it's used during ocular surgery. Okay. These agents are often used prophylactically, and that's just to prevent postoperative infection, especially when we talk about the delicate structures of the eye. There is ophthalmic anti-infectives that are so vital for treating and preventing eye infection, especially with a strong emphasis on, okay, patient, you just had this particular procedure. This is your post-operative care instructions, because we do want to ensure that there is a successful surgical outcome. Now, we cannot talk about eye drugs without anesthetics. There are ophthalmic anesthetics that interfere with the transmission of pain impulses. Now, what it does is provide relief during procedures. They block the pain signal from reaching the brain. Now, this makes surgical procedures just that much more comfortable for patients. Now, why are they unique? Well, anesthetics are unique because they specifically target pain pathways by doing that, interfering with transmission of those pain impulses. And that really helps our surgeons to perform those really delicate work without causing the patient discomfort. Now, in surgery, I can attest that the patients that I have worked, or the surgeons that I've worked with, our patients have been under general anesthesia. But there are like outpatient surgeries in different places where the patient may be awake. The one scene that comes to my mind is from Final Destination. Don't ask me why. And she went to go get her eyes done. She was getting LASIX, and she was awake. Now, granted, everything that happened afterwards, we don't want that to happen. But the fact that, she was awake in that particular case. Okay. So some common examples: tetracaine, alkane, propylparacaine, both are topical anesthetics. They're usually available in 0.5% ophthalmic solution, and they are applied topically or injected, believe it or not, to provide localized pain relief during ophthalmic procedures. They are so important because let's say you have a patient like or a procedure like a cataract and you're removing cataract removal or even any other eye surgery where the patient must remain still and without discomfort. They're awake. Okay. Now, there are different routes. Like I mentioned, you have your drops or you have your ointment. It's going to be injected directly into the tissue. Now, ophthalmic anesthetics are so important because we're still trying to maintain pain management during eye procedures. And their application is going to really be tailored to whatever procedure and really what the patient's needs are. Now, we talk a lot about anti-glaucoma. Anti-glaucoma agents are used to treat none other than glaucoma. And this is a condition characterized by increase intraocular pressure, or IOP, which can really go in and damage the optic nerve. And that's where you start seeing that vision loss if it's not controlled. But why is this so important for us? Well, glaucoma is often referred to as the silent thief of sight. I will repeat that. Glaucoma is often referred to as the silent thief of sight because it usually develops slowly without any real like noticeable symptoms until significant damage has been done. So lowering the IOP is going to be really important to just prevent optic nerve damage and really preserving vision. So from miotics or mydratics, which one do you think we were going to want to really use? Do you guys remember which one constricts and which one dilates? Which one are we going to want to use? So we're going to use miotics, okay? Because they're going to constrict the pupil and improve the drainage of aqueous humor, which is going to lower the IOP, okay? There's also beta blockers. They're going to reduce the production of aqueous humor again, which is something else to help lower that IOP, intraocular pressure. There's also progrescalin, I think I said that correctly, where this increases the outflow of aqueous humor, therefore lowering the IOP. And there's carbonic anhydrase inhibitors. These decrease the production of aqueous humor, again, lowering the IOP. Now, all of these agents help ensure the health of the optic nerve. And that can be used as part of a long-term treatment plan to really manage glaucoma. Again, keep in mind that anti-glaucoma agents are going to be so important in treating and managing glaucoma by reducing elevated IOP, intraocular pressure, really helping prevent that optic nerve damage. And again, we're trying to preserve the vision. So let's watch a really, really quick, it's like 40 seconds video on glaucoma. If it's going to let me play it. There we go.
Clear fluid flows through the anterior segment at the front of the eye, nourishing tissues. At the open angle where the cornea and iris meet, the fluid flows through a spongy meshwork and leaves the eye. But if it passes through too slowly, pressure inside the eye rises to a level that damages the optic nerve, resulting in vision loss due to open-angle glaucoma. Untreated, the vision loss progresses from normal vision and no pain to gradual loss of peripheral or side vision and eventually total vision loss.
I love it. It was quick, fast, and kind of brings it home. As you can see, you go from normal, normal, normal to next thing you know, that intraocular pressure is so bad, the nerve is damaged, and now you can't see. So we look at our agents, okay? Drugs like mannitol. They pull the fluid out of the eye by increasing blood osmotic pressure. This again lowers our AOP very quickly. So mannitol is often given during retinal surgery for rapid IOP reduction. We have alpha adrenic agonists. They lower eye pressure by reducing fluid production, and then sometimes they help improve the drainage, and of course the damage. So we have aproclodine. I think I said that correctly. It's used for sudden, like the IOP spikes. So then they're going to give them that. We have Brimodin, which lowers production, increases outflow. And then we have epinephrine and diprivirin. It's used with other agents. Again, everything is to reduce the IOP. With your beta adrenic blockers, what they do is they're in the ciliary body. They reduce fluid secretion. Common in long-term glaucoma management. So these patients already know they have it. And so they're doing this to kind of maintain it. So some of the examples, Timol, which is widely used. We have beta-axol. This is safer for patients with, like, let's say they have breathing issues, COPD. And then we have metoprolol, which also just helps with lowering the production. The other one up here that the chapter wants you guys to know is carbonic anhydrase inhibitors. These work as an enzyme that helps produce aqueous humor, reducing fluid buildup. Um, One of the examples from the book is acetylzolomide. This is given orally or IV, depending on where the patient's at. And this is going to be for acute or resistant cases. They have topical forms. Brenzolamide is one of the topical forms. And then the last one down here are your PGAs, your prostaglandin analogs. These are the first line therapy for glaucoma. So it's like one of the first things they're going to get. What it does is it increases fluid drainage through a secondary pathway. So you have travoprost, which is one of the examples. Quick summary. Miotics constrict pupil, better drainage. Beta blockers decrease fluid production. Alpha agonists lower production, improve outflow. And I'm going to give you guys this little chart that I made so that you guys can kind of have it as a resource. We have our carbonic anhydrase inhibitors, decrease production. You also have mannitol, the medication, pulls fluid out quickly. And this is really useful in surgery. So here's a question for you guys. If two drugs can both lower IOP but work differently, meaning let's say one reduces fluid production, the other increases outflow, how should a surgeon decide which one to use? What do you guys think? How are they going to know? Like, both of these drugs are trying to lower the IOP, but one is going to reduce the fluid and the other one is going to increase the outflow. Which one would I use? And I want you to think about the patient.
Would it be because of the like their levels? Like something about their levels? I don't know.
Could be. That could be. Keep throwing them. That's good. That's the one that's not contraindicated. That's a good one. Look more specifically on the patient though. Um, I don't want to give it. Well, I'll give it. It's going to depend a lot on the patient's condition. Is it acute versus chronic glaucoma? Because remember, one's going to be for a more longer term, and one's going to be, let's say there's a spike and we need to get this IOP down immediately. There's going to be other issues. Does the patient have asthma or kidney disease? That could really determine the contraindication, right? And then the urgency of surgery. We have to consider both the mechanism and patient specific factors when thinking through these decisions. Okay. So that was just something to kind of, ponder on. We also have anti inflammatory agents. We got to control swelling and inflammation, especially after eye surgery, just like with every procedure, right? We always are going to be thinking about swelling and redness, and we're going to be looking at that even in the eye. So there's steroids or corticosteroids where we're reducing corneal swelling, we're trying to prevent scarring and calm down that inflammation. But we do not use steroids if infection is present. We do not use steroids if infection is present. They're not going to kill the bacteria, and they may actually hide the symptoms. An example that you guys have probably heard of prednisone. With NSAIDs, these are our anti-inflammatory drugs. They prevent or treat eye inflammation, especially after cataract surgeries, iritis, or even conjunctivitis. So, ocular is a drug I'm not sure if you guys have heard of. Now, steroids used after surgery to reduce corneal swelling and inflammation. NSAIDs prevent complications like cystoid macular edema, so edema going on after, let's say, a cataract surgery. We have our diagnostic stains. Why are we having these? Well, they're helping us to color or mark tissue for diagnostic purposes. Now, I created an image that was extremely bold to kind of just give you some type, visuality of what. Okay, so we're not turning the eye blue, just so you guys know, but I just wanted you guys to have a visualization of the dye. Okay. Now, dyes are used again to highlight or identify specific tissues. That helps with visualization and accurate assessment. These stains are going to be used to really help identify areas of the eye that may need treatment or monitoring during certain surgical procedures. So, more realistic, okay? We have fluorescein sodium. Those that get our eyes dilated, we're kind of used to that little dye, little stick going in. There's rose Beniguel, there's lysamine green, and there's indocaine green. These dyes are used to, and that's an eye, just so you guys know, to color or mark tissue. Okay. They're trying to see what's going on with the eye. They're helping highlight areas that are damaged. They're locating sometimes foreign bodies that you may have to pull out or assess the flow of what's going on with the aqueous humor. And a lot of times when we're doing a lacrimal duct case and we're trying to get the lacrimal duct open, we're going to put in the dye to make sure that we're getting that lacrimal duct indeed open. So fluorescein, okay, used to identify corneal abrasions, assess again lacrimal duct function. What it does is it stains the damaged corneal tissue green. So then now you see that green, now we can say, oh, that's an abrasion. With rose Beniguel, primarily used for diagnosing dry eye syndrome by highlighting devitalized and conjunctive epithelium. So it's going to highlight where the eye is not getting enough moisture. Typically used in office. So it's not going to be something that you're going to necessarily see. Not saying you can't, but it's going to be more bedside or chairside. Okay. For lysamine green, similar to rose Beniguel, again, we're just trying to diagnose dry eye. But again, another one used chairside or office setting. For indocaine green, this last one down here, this is going to be used for ophthalmic angioscopies, where now the surgeon is trying to visualize the cortical vascular network that's going on in the eye, but it is administered IV outside surgery, so it's not going to be typically used in surgery. All of these stains help to improve accuracy of diagnosing conditions affecting the cornea, the conjunctiva, really just the overall eye health. So we're getting closer and closer to the end. So what questions do y'all have for me? Because I have some questions for y'all. But what questions do y'all have for me? Okay. So for those of you who are watching, you're going to be able to see these same questions. Starting next week, I'm working on getting more scenario-based questions so you guys can get more comfortable as we get closer and closer to the final in our polls and in our Quizlets. Kahoot is limited on how many characters I can put in. So unfortunately, our Kahoots, I can't really put in more scenario-based, but I'm going to see what I can do as far as your Quizlets and, of course, this course. So for those of you who are watching, again, there's 10 questions. You guys will have 5 minutes to complete. So it's like 30 seconds a question. Um, and then once we are all done, we will wrap everything up. And in about 2 minutes, I'll go ahead and switch it so those of you who are watching will still have the same opportunity to see these questions that we are kind of going through in the live session. So those of you who are here, take your time, 5 minutes. We'll be back to wrap it all up. Okay, gonna go ahead and end the poll. Okay, so again, we talked about a lot of I's. Okay, we identify terms, abbreviations related to the eye and ophthalmic agents. We had to break down the eye itself. Okay, we looked at the anatomy, including structural layers, and even the accessory components. We discussed common categories of ophthalmic agents, as well as examples of each. And then we identified a lot of medications that, if you work in eyes, you will most likely be used to. BSS, BSS, BSS. Don't forget that. And we talked about medications used to treat glaucoma and explain the mechanisms of actions, especially when it talks about intraocular pressure. And you guys understand why that's so important, right? Because we do not want um, the patient to go blind. For those of you who are watching the discussion forum, how does understanding the anatomy of the eye help us properly administer ophthalmic medications and avoid complications? Why is it important to really recognize the difference between common ophthalmic agents like mydratics, miotics, and anesthetics? And how do these differences really impact patient safety? And what role do glaucoma medications play in preserving vision? I do want to give you guys your flowers. Both this course and in 300, you guys are really doing phenomenal. We have, again, 3 weeks left. Let's keep up that momentum. We're almost there. If you do have any questions about anything from either course, y'all let me know, especially as we get closer and closer to that final. I want to make sure that you guys are comfortable and confident walking into it. Okay. With that, thank you all for being here. Please have a wonderful rest of your evening, and I look forward to everyone who can attend tomorrow's live session. Good night, everybody.